Hey, this is Sarush Hashemi, family physician in Wilkes-Barre, Pennsylvania. Wanted to talk for a bit about diabetes mellitus. I wanted this to be sort of a practical talk. When I finished med school, I had a lot of theoretical knowledge, pharmacology, pathology, but I didn't have a lot of practical knowledge of how to specifically treat um, this disorder and how to counsel patients. So this is sort of intended for both the general public, but also for up-and-coming practitioners. This disorder is first named diabetes mellitus, coming from the Latin phrase, the passing through of sugar or the passing through of sweetness. Essentially, it was noticed very early on in history that people with this affliction have excessively sweet urine and blood. So diagnostically, we do fasting blood glucose is the standard test of choice. Sometimes I'll take this off of just a basic metabolic panel, which I'll order along with a lipid panel in just a general well visit. There is a recommendation to screen every 3 years for diabetes in a patient with hypertension. So fasting blood glucose, which can also just be done with a finger stick, between 100 and 125 is the pre-diabetic range. You can also check via an A1C, although this is a slightly more costly test, so it's not first-line recommended, but it is often done. And an A1C of 5.7 to 6.4 is considered pre-diabetes. Fulminant diabetes is a fasting blood glucose over 125 or an A1C of over 6.4%. And then there is the most two common types are type 1 and type 2. There is, among some people, a little bit of confusion over how to differentiate the two. Some people think that it simply has to do with whether a patient is on insulin or not. However, that's actually not true. Type 1 is a autoimmune disorder in which the body's immune system creates antibodies which attack the part of the pancreas which produces insulin, the beta cells. Type 2 was originally thought only to have to do with obesity, but it is more multifactorial than that. There's a lot of systems involved. However, it's associated with insulin resistance, meaning the body can produce insulin, but it just doesn't respond appropriately. And often that does have to do with excess adiposity or an excess of body fat. Fat cells themselves secrete hormones which counteract the effects of insulin. If you really want to be academic about it, there are blood tests you could do to tell the difference, including anti-GAD. C-peptide is a protein which is part of the zymogen form of insulin, which is cleaved off during the process of producing insulin. So if a human is making a appropriate or even excessive amount of insulin, like in a type 2 diabetic, you would have an elevated C-peptide. In a type 1 diabetic who's not producing insulin, you'd have a low C-peptide theoretically. However, there is some leeway, some overlap between C-peptide levels. You can also check anti-insulin and anti-islet cell antibodies or just an insulin level. Type 1 does usually tend to present earlier in life. Type 2 can be much later. However, some people do get late onset type 1. And some type 2 diabetics are actually not overweight, believe it or not. My sources, I use this this document by the American Diabetic Association. They release it every so often, every few years, and it's very comprehensive. It's a very long publication, several hundred pages. So I use this. I also used a couple of other books, and then also I had the benefit of picking the brain of a very astute and illustrious endocrinologist out here. So essentially type 1 diabetes, as I mentioned, younger onset, the treatment is essentially always just insulin. That's because the body of a type 1 diabetic, the pancreas, just can't produce insulin. So that's the real issue here. There are some up-and-coming treatments for this. There's talk of beta cell transplants, which is pretty interesting. And then also there is a bionic pancreas being worked on by several different academic and pharmaceutical institutions, essentially just a device that works a lot like an insulin pump and a glucose sensor, but the two work together in one unit. So this device should, in theory, be able to check your blood sugar and administer a appropriate amount of insulin. Might even be implantable at some point, which will be great. And then you just get this device and you can just move on with your life. Some designs might include a glucagon vial as well in case of an emergency hypoglycemia. So essentially that's what this says. These are the recommendations for treatment of type 1 diabetes, essentially just insulin. Well, to dose insulin, I'll just tell you, you can basically take a person's weight in kilograms, divide it by 2, and that's how many units they would require theoretically as a starting dose. So then you divide that number. Let's say I'm a 100 kilogram man. Divided by 2, you're going to give me 50 units of insulin per day. Then you divide that again by 2, so 25 and 25. And those are your basal and bolus insulin types. Basal insulin is a long-acting insulin given before bed. Bolus insulin is usually given 3 times a day before meals. Some people say split it 60-40, give a little more of the basal. Some people say keep it 50-50. There is some user discretion involved there, but that's the basics of insulin dosing. Type 2 diabetes is what I'm going to spend more time talking about here. It's more common, and as I said, it's not just about insulin resistance. There's multi-systemic issues involved. The gut incretins are involved. The kidneys are involved. Muscles are involved. The brain, the liver. And then also, of course, the pancreas doesn't secrete enough insulin to keep up with the body, and then also there's increased glucagon secretion. That's a hormone that raises your blood sugar. Insulin is one that decreases your blood sugar. The problem with insulin, though, is that it's also a growth hormone. So once we put somebody on insulin, it's really hard for them to lose weight. It basically causes a storage of fat. This is actually also why low-carb diets are pretty effective in helping people lose weight rather quickly. It's because carbs are one of the impeti for the release of insulin. Once insulin is released, it causes a storage of fat. So when you cut out carbs, you don't secrete as much insulin and you don't store as much fat. That's the theory behind low-carb diets. I'm not saying they're necessarily the healthiest way to lose weight, but they are effective, and that's why. So the recommendations for treatment of type 2, as I said, I don't really like insulin for that reason. It's hard for people to lose weight, and people can drop their blood sugars, and I really want to see a type 2 diabetic get fit and healthy, as well as getting their blood sugar under control. So if I can avoid it, I do. The first medication, and people love oral medications before they go to needles, of course, is metformin. It's been around a long time, and that, as you can see, is the first line agent, and I'll tell you more about that in a minute. But then they also do go into the concept of putting a type 2 diabetic on insulin. That's because it's the easiest way, the most effective way to lower blood sugar. And once you get past a certain level, your cells just won't really be able to respond to any of these other medications, because they're just so used to being bathed in really concentrated sugar water. Insulin causes the intake of sugar from the blood into the cells. And when you have such a heavily concentrated extracellular fluid full of sugar, the cells don't even really need to use that mechanism anymore. They're just bathing in it. It just osmotically crosses their membranes. So they pretty much don't really respond to these other meds that would almost be considered half measures. They don't really say what A1C is the necessary one to start insulin. So it is kind of user dependent. And as they say on the right side, a patient-centered approach is what's most important here. There's no necessarily 100% right way to treat diabetes. It depends on each, individual patient is different. This is their algorithm for treating diabetes. They go through all of the oral options, and then they also talk about adding insulin. I found this to be a little bit of a busy and for me even intimidating slide, so I'm going to break it down for you. Here's a list of the most commonly used medications, and you see at the very bottom, interestingly, surgery can be beneficial. Most endocrinologists will at least discuss it with their obese patients. Gastric bypass can cure diabetes in a lot of cases and prevent complications. However, surgery also has complications of its own. So as I mentioned, metformin is the most common first-line medication for type 2 diabetes. And there is even some talk of maybe trying it for type 1 diabetes because it decreases insulin requirement and increases sensitivity, supposedly. I've read a study or two that suggests that. But most type 1 diabetics don't get metformin. It's in the drug class called biguanides. It's pretty much the only one in its class that I've ever used. It works on the liver by decreasing the amount of sugar the liver produces. There are two forms. There's the immediate release and there's the extended release. Immediate release is a little more effective. Also goes by the name glucophage. You start at 500 milligrams twice a day and increase per week to 1,000 milligrams twice a day. There is a max dose as well, but nobody really tends to go over 1,000 a day. Suggested to take it with meals. There's not really a big risk of hypoglycemia, of dropping your sugar too much. There is some talk of kidney disease and metformin, which can get a little complicated. The point is, metformin is actually not bad for your kidneys at all, but it's filtered out by the kidneys. So if you have a person who has a failing kidney, i.e. their glomerular filtration rate is less than 30, you should probably stop metformin because the drug is not going to get filtered out as effectively and they run a risk of side effects. There was also some talk of stopping this medication for iodinated contrast studies, like if I'm getting a CT with contrast. That was academically implemented for a long time, but then it turned out people just kept forgetting to stop metformin before contrast studies, and nothing seemed to really happen. Like people didn't get sick from it. So now that recommendation is actually contested in some circles. So the basic recommendation for kidney problems, don't start a patient with a GFR of less than 45 on metformin, and if their GFR goes less than 30, stop metformin. Side effects, lactic acidosis is the big one that they taught us about in med school, meaning a buildup of lactic acid in the blood. More commonly, I just see some people get a little bit of a stomach ache. Usually that goes away after a week or two on this medication. And B12 deficiency is also an interesting academic side effect, often on tests. That's especially important in patients who have had gastric bypass, as they don't absorb B12 as well. Patients on antacids also don't absorb B12 as well. So if they do have a really bad stomach ache from metformin and they just can't stay on the IR form, you can try the XR form, the extended release, and you start that at 500 milligrams at night. That's the main reason to switch from the short-acting to the long-acting form. And as I mentioned, the IR form, the immediate release of metformin, can decrease your A1C pretty effectively in a lot of cases by 1.5%. Next class are the sulfonylureas. They are secretagogues, meaning they stimulate insulin secretion from the pancreas. They essentially tell the pancreas, hey man, work harder, what are you doing? They have side effects of weight gain, which is a little bit of a problem again because I want my type 2 diabetics to be able to lose weight. They also have a higher risk of hypoglycemia, meaning dropping your sugar a little too much. And glyburide is the one that does that the most, according to the American Academy of Family Physicians. Again, with kidney problems, these drugs are not filtered out as effectively, so you run a risk of dropping your sugar too much. So if a GFR is less than 60, maybe consider decreasing the dose, and then again, that number GFR of 30, consider just stopping the sulfonylurea. But again, they can be pretty effective, decreasing the A1C up to 1.5%, and there's this phenomenon called ischemic preconditioning, which is essentially a benefit long-term to the heart, preventing ischemic events, preventing heart attacks, in theory. The one that I use the most and that I've been told is the most effective is glimepiride, which also goes by Amaryl. You start this at 1 to 2 milligrams per day, and then you increase it by 1 to 2 until you get to the max or the most effective tolerated dose. Give this with a meal because, like I said, it can drop the blood sugar. And then again, with kidney or liver impairment, you start a little lower and you go a little slower with your increasing of doses. And I'm going to put all of these drug classes together on my final slide, and I think it'll all come together pretty well. The next class is the glinides. These are also secretagogues. They're similar to sulfonylureas, but they're a little better in kidney problems, and they are used with meals. So for a person who has dropping blood sugars because they're on a sulfonylurea but don't eat, that's why you could consider switching to a glinide instead. They are supposed to be similarly effective to the sulfonylureas, and it can also cause some weight gain. Same thing with the kidney. They're also filtered by the kidney. And the most common one that I see used is repaglinide or Prandin, and that's 1 milligram before meals. There is also a second glinide which I see used, which is Starlix or nateglinide, and that's better for patients with kidney problems. Next is the TZDs. These work as PPAR gamma agonists, which is kind of a complex endocrinological system, but essentially they work by increasing the insulin sensitivity in adipose and muscle. So now we're in the tissues, and they are working more effectively with less insulin. These are slightly less effective, but they do decrease A1C by approximately 1%. They have a lot of side effects. That's why they're not used that commonly. Actose or pioglitazone or rosiglitazone was the old one that had some cardiac side effects, and it's pretty much off the market now. They can cause some liver problems. They can cause fluid retention. That's a big one, especially on tests, which can cause congestive heart failure exacerbations. They're also supposed to be possibly associated with bladder cancer and bone fractures. The benefit is that they're weight neutral. They don't cause weight gain, and they're safe in kidney failure or patients with renal impairment. They do also supposedly slow the progression of diabetes, and except for rosiglitazone, they're supposed to possibly decrease the risk of coronary artery disease, strokes, and fatty liver. They're shown to decrease triglycerides, increase healthy cholesterol, and they have some other benefits as well. They don't have as much of a risk of low blood sugars. And the risk of hypoglycemia is increased if the patient is already on another medication that causes hypoglycemia, like a sulfonylurea or insulin. So the way I would dose this, I would put them on Actose, pioglitazone, 15 milligrams a day, and then titrate up as needed. Don't really need to go over 45 milligrams a day because there's not really going to be much added benefit, and there's no renal dosing, which is a benefit. This drug class is one that I do see used very often, the DPP-4 inhibitors. They essentially block the degradation of those incretins, which were the hormones secreted by the gut itself. There's glucagon-like peptide and gastric inhibitory peptide. GLP-1 is that glucagon-like peptide. It's secreted by the distal small bowel and proximal colon in response to glucose, and it increases the sensitivity to insulin. Diabetes mellitus type 2 is associated with an increased resistance to that GLP-1 as well as insulin. And I believe in diabetics, you can have a increased insulin and decreased glucagon response because of that. So DPP-4 inhibitors are contraindicated in pancreatic disease. There are some reports of unexplained pancreatitis when on this medication, but there is a lower risk of hypoglycemia. They seem to mostly just work in the presence of glucose. That risk is, of course, increased in patients on sulfonylureas or insulin. And another benefit of these DPP-4 inhibitors is that they are weight neutral. They're fairly effective, not as good as the last classes we were talking about. They, in theory, will just decrease A1C by 0.7%. I do see a lot of this being prescribed Januvia or sitagliptin. It also comes in a combination pill with metformin, Janumet. Optimal dosing, 100 milligrams a day, and then titrate up as needed. There is a renal dose for this as well. This is one class that is pretty valuable and that I use a lot. The only problem is that it's subcutaneous. It's an injection once a day. But the GLP-1 receptor agonists work along that same pathway. GLP-1 has several other roles. I can't really list them all for you right now, but it agonizing the GLP-1 receptor is associated with weight loss. And in fact, there is even a drug called Saxenda, which is a version of this, which is just strictly for weight loss. It's a very high dose of a GLP-1 receptor agonist. It's also associated with cardioprotective effect, meaning less risk of heart attacks down the line. And remember, patients who have diabetes are at increased risk for heart attacks, regardless of what their A1C is. It's just another risk factor. They're also at increased risk for strokes and kidney disease. Side effects include stomach ache and diarrhea. Some people get a little nauseous. Usually this goes away also, but these symptoms will often curb appetite, which helps with the weight loss. They have a low risk of hypoglycemia, which again is increased with sulfonylurea or insulin, but similar to the DPP-4 inhibitors, theoretically they only really work in the presence of glucose, so pretty low risk of hypoglycemia. And oftentimes if I see a patient who's on insulin, type 2 diabetic, and is having hypoglycemic episodes, I will cut their entire insulin dose in half and start one of these. Start Victoza is the one I usually use. So Victoza is the one, like I said, that I usually use, or liraglutide. You start at 0.6 subcutaneously in the morning, and then increase as tolerated weekly, with the max dose being 1.8, and that is pretty effective. If treatment is interrupted for more than 3 days, you have to start over with the titration. And there is a couple of other versions of this class on the market, one of them being Tanzium or albiglutide, which is associated with less stomach aches, less nausea, but is slightly less effective. A benefit is that it's only once a week dosing instead of a once a day injection. Another pretty interesting and pretty effective class is the SGLT2 inhibitors. These work on the kidney. They cause increased secretion or decreased reabsorption of glucose through the kidney. So you basically urinate out the sugar. Usually this channel, the SGLT2, reabsorbs glucose at the proximal tubule at about 100 milligrams of glucose in a 24-hour period. SGLT1 is at the distal tubule. That's kind of just physiologic, almost semantics. Sorry for that. But they do decrease the A1C up to about 1.5% if the GFR is effective. There are some side effects which include dehydration, yeast infections, and UTIs. So frail, older patients, especially females who are prone to recurrent UTIs or yeast infections, this may not be the best drug for them. You can still try it and stop it if they get reoccurring infections. But like I said, it's best if they have a normally functioning kidney. And added benefits of this, which are kind of important, are they can lower weight but also lower blood pressure. And it's thought that they have some long-term kidney protection and maybe even some long-term heart protection. Most effective is empagliflozin or Jardiance. That's started at 25 milligrams a day. Started at 10 and then titrate up. Invokana is another version of this class, which for some reason some insurance companies like to pay for before they'll pay for Jardiance. So here's that slide I was telling you about where I tried to put it all together for you. So let's go through this, and this is, I keep a picture of this on my phone for when I need a reference. So with a type 2 diabetic, we don't want to put on insulin. These are kind of the main options here. These are the heavy hitters. Start with metformin. Start them lower at 500 twice a day, but titrate up. The effective dose you want to get to is 1,000 milligrams twice a day. Those are the side effects: nausea, vomiting, dehydration in some cases. Those are the renal dosing that you have to worry about, the GFR. And consider stopping it if you're getting IV contrast, but not absolutely necessary at this point, I can't say. But they're effective in that they can, metformin, is effective in that it can decrease your A1C by about 1.5%. I'm just going to skip over right to the right side of this slide because most of my type 2 diabetics are overweight. So these are the drugs that I would like to put them on, ideally, are the weight loss drugs. The first one is Victoza, as I mentioned, that liraglutide. That one you want to get up to the max dose, which is 1.8 milligrams subcutaneous Q24. As I mentioned, it can cause some stomach aches. There is some risk of supposedly medullary thyroid cancer and pancreatitis with this medication. But from what I understand, the risks are pretty low. And they cause weight loss, and they also cause a reduced risk of cardiac issues in the future, which is really important for diabetics. And as you can see, they're kind of the most effective with a decrease in the A1C of 1.7%. Also in the weight loss column is empagliflozin or Jardiance. That's one of those SGLT2 inhibitors, which causes you to urinate out the sugar. This you want to get up to, again, these are all the most effective doses in my experience, the 25 milligrams by mouth every 24 hours. Stop it if they go into kidney failure, which I don't believe this causes that. I'm just saying, again, it won't be as effective, and you run a risk of side effects if the kidney is not filtering at greater than 45. Long term, this is actually good for the kidney, the SGLT2 inhibitors, and decreases blood pressure as well. But you have to watch out for things like dehydration, UTIs, and yeast infections. And as you can see, it's pretty effective with a decrease in A1C of 1.5. In the weight neutral class, there's the TZDs or pioglitazone. That can have some side effects, as I mentioned, so it's not used that often. But the most effective dose is 30 milligrams a day. And it can also have some cardiac protective effects and is okay in renal impairment. And is pretty effective by decreasing the A1C at about 1%. Sitagliptin is the next in the weight neutral category. It has a max or most effective dose, I should say, of 100 milligrams every 24 hours. Stop this if they develop pancreatitis. It's okay in renal impairment, and decreases in A1C kind of modestly at 0.7%. And then in the weight gain category, unfortunately, again, insurance companies really like to pay for sulfonylureas because they're cheap. So most people after metformin get put on a sulfonylurea. The most effective one in my experience is glimepiride, which can decrease your A1C up to 1.5%, which is good. Glyburide, as I mentioned, is the one associated with the greatest risk of hypoglycemia. So glimepiride, you put them on 4 milligrams just once a day. It has a cardioprotective effect, which is known as ischemic preconditioning. It does have that risk of low blood sugars or hypoglycemia, so you need to watch with declining kidney function. The glinides were also in that weight gain area, and those are the ones that I said if you have a patient on sulfonylurea that is getting low blood sugars because they forget to eat, maybe consider switching them to the glinide class. So repaglinide is the most effective one in my experience. Put them on 4 milligrams a day pre-meal, so they're taking it with meals. And there's less of a risk of hypoglycemia, less risk of, I believe, also cardiac events. If they skip a meal, they can just skip their dose, and slightly safer in renal impairment, but there is still a renal dosing mentioned there. And as you can see, it's slightly less effective than glimepiride at an A1C decrease of 1%. So here's my works cited. This is kind of just for your education. I wouldn't base my entire therapeutic approach, obviously, off of this YouTube video, but I wanted to give you guys some background on what I've learned so far. So I hope this helps. Hippocrates is another good app if you're looking for specific dosing, and of course, always consider an endocrinology referral if needed. Thanks a lot.